Good afternoon, all. Thank you for joining us. Today, we're joined by Opal Greenway and Zach Bozer to be speaking on the topic of primary care options for rural areas. And so with that said, I will turn it over to our presenters.
Thanks, Laura. Well, thank you everyone for joining us today. We want to talk to you guys about primary care options for rural. We're going to be talking about designations and what are your best options with regard to those designations, but also importantly is we're going to tie the intersection of RHCs and those designations with practice operations and some best practices, and give you guys some information about what we're seeing right now from a performance standpoint, and how these things interplay with one another so that you guys can think about it strategically and what are going to be your best options given the regulatory, provider recruitment, retention, and operational and staffing shortage market that we're all experiencing right now. So just letting you know a little bit about Stroudwater is a 37-year-old healthcare provider strategy, operations, and finance consulting firm. We work entirely with hospitals, health systems, and independent physician practices. Our focus is on the rural market. We have specialized and lended our expertise to rural providers, communities such as the ones here in Oklahoma that we are talking to today, understanding the nuances and the practical realities of what happens in rural markets and how can you actually intersect what are the specific regulations and options available to you with those realities to have a successful healthcare organization that preserves and enhances healthcare access to everyone in your community and being good stewards of the resources available to you to provide those kinds of healthcares. So I'm Opal Greenway. I have been a principal at Stroudwater Associates. I've been with the firm for 8 years and I lead our physician advisory group. Joining me today is Zach Bozer, a senior consultant with Stroudwater Associates, who has been working with me in the provider group, who is also a former critical access hospital CFO himself and is an expert in finance and rural health clinics. So again, thank you for everyone for joining us, and let's get right into our agenda. So as I mentioned today, let's go ahead. We're going to start off with a little bit of an overview as to why we're talking about this. Then Zach's going to walk you through some definitions and regulations of the designations that will be impacting this and what your strategic options are for aligning your primary care and setting it up. We're going to go over some characteristics of what are better performing practices so that you can think about where you are currently and how does that compare to the characteristics that we see in these better performers. We'll walk through a couple of case studies of organizations who have considered their designations and their different options that they have in healthcare or for primary care to execute upon and what the financial impact of that is. And then we'll close out with some best practices that you can implement within your organizations to move those practice options forward. So just to set the stage as to why we want to talk about this and why are we talking about it a lot of times from the lens of hospital-owned practices. The reality is hospitals have owned physician clinics for years, and oftentimes the way they go about owning provider clinics is they've purchased it from a physician themselves. And so when hospitals tend to buy up practices, regardless of the designation of that, they take a practice where the physician might say, hey, this practice was, we're making a little bit of money. I don't want to be involved in the management of a practice anymore. I might have a retirement plan. Hospital A, I've been very aligned with you. I've referred patients to you for years. Would you like to buy my practice? And oftentimes hospitals are opportunistic and they end up purchasing that practice and then coming into their system. The consequence is that many hospitals and health systems actually really host practices rather than manage them. So they bring a practice online to the hospital, and oftentimes it is freestanding. Maybe it's even provider-based as a clinic, and they continue to let the practice operate the way that it did historically. And they focus on how can we tap into revenue sources? Maybe we're looking at, hey, how do we 340B? But they don't actually take over the true operations of the clinic in what we would consider a best practice way of really focusing on how do I run a clinic? And running a clinic is different than hosting a clinic, and understanding that running a clinic is also different than running a hospital. You have an entire cohesive business unit. You don't have a separation between the nursing staff, the clinical care staff, the revenue cycle staff, and your front desk and your patient service representatives, as well as the dynamic of the practice providers. Oftentimes the clinic is not located within the four walls of the hospital, or it might even if it is attached. And so the way you run a clinic is significantly different, and understanding those operations and how to set it up for success is really critical for having what we consider taking advantage of these clinics and really putting them in their best place to actually, in a lot of cases, to at least be able to be break even in rural, given the different options that we're going to go through today. And so there's a lot of reasons why this happens, whether it's just being opportunistic and not having a strategy around buying those practices, not having the right infrastructure in place, having to make significant infrastructure investments, such as converting EHR systems, overly consolidating things such as a call center or revenue cycle where the practice is not as involved in the day-to-day anymore, not thinking about what your designations should be and thinking about where consolidation should happen, having clinics that are too disparate and not taking advantage of different consolidation on the cost report. They let clinics continue to run however they were done previously, and they don't have any standard operating procedures or scope of work for all of their different people that are working in the clinics. And so without that consistency, you can't have a float staff, and people build upon those inefficiencies and they tend to compound. And then finally, you don't set up your revenue cycle or your provider contracts in a very uniform manner. So all of these things can result in some pretty poor performance in some of these clinics, which can make people a little bit gun shy about investing in primary care. But there are ways to actually address this. And one of the key ways that we're going to talk about today is what the clinic designations are, and how you can utilize that to offset some of and create yourself some financial upside with these clinics, so that it buys you the runway to address some of the other operational issues. So that being said, as I mentioned, Zach's going to go through the definitions and the regulations pertaining to these, but the specific primary care options that we want to talk about for building out this really good primary care base. It's going to be referrals for your hospital, but not just the referrals, but the location of where a lot of services are going to be provided in the future. We've already been seeing the shift from inpatient to outpatient, and this is just going to be compounded going forward. So the designations we're going to be talking about today, I've already mentioned the freestanding health clinic. This is the most common designation when you buy up a practice. And we're going to talk about whether or not to convert that freestanding health clinic into a provider-based clinic, a rural health clinic, a provider-based rural health clinic, and then also make sure we touch upon federally qualified healthcare centers that are a designation available to us in many of our rural communities.
So thanks, Opal. Everyone, great to be with you this afternoon. I will begin speaking about the practice designation types. And as Opal mentioned, the designation of your practice can have a significant effect on reimbursement. And so based on the four designation types for clinics that Opal had mentioned on a previous page, we've created a bit of a matrix here, kind of looking at what are some of the pros and cons of the different designations. So we see all the way over to the right, as Opal had mentioned, most clinics come in kind of designated as that freestanding health clinic. And, we're looking at alternate designations, whether it be, federally qualified health center, provider-based clinic, or a rural health clinic. And so if we look at the matrix, some of the, going down the list, looking at the 330 grant revenue, this is something that is specific to a federally qualified health center. It's funding from HRSA to support the provision and comprehensive primary care services for underserved communities. So that's the only designation that is afforded 330 grant. Next is the 340B contract, 340B pharmacy program, contract retail pharmacies and drug pricing reductions for 340B drugs. The FQHC is also able to participate in the 340B program. Provider-based clinics underneath a CAH CAHs are automatically eligible to participate in 340B. So for both the critical access hospital provider-based clinic and the rural health clinic. And PPS hospitals that meet the minimum required DISH percentage, which is 11.75% DISH percentage, they're also eligible to participate in the 340B program. So any clinics aligned underneath a critical access hospital or PPS hospital that meets the DISH percentage, provider-based clinics or rural health clinics are eligible to participate in 340B. Advanced technical charges for a critical access hospital and for a rural health clinic. This is not afforded to FQHCs, PPS provider-based clinics, or freestanding health clinics. Method 2, that's specific reimbursement for critical access hospitals, where for outpatient services, the professional component is reimbursed at 115% of the Medicare fee schedule. So again, specific to provider-based clinics underneath a critical access hospital. Rural health clinics have their own reimbursement methodology. And then, the tort reform malpractice savings, that's specific to the FQHC. So FQHCs are eligible to participate in medical malpractice protection at no cost to grantees under the 330 grant program. So this is a cost savings that can then be used more for providing clinical services. So that's a specific benefit for FQHCs and no other designation. And then enhanced PPS reimbursement also afforded to FQHCs, provider-based clinics underneath a CAH, and rural health clinics. So I think the big takeaway here is to look at the FQHC, to look at the freestanding health center all the way on the right and see that they're not able and eligible to participate in any of the benefits that the other designations are afforded. And so it's really important to kind of look at that and say, what makes sense from our hospital and system perspective to look at, designation as a different type of clinic. I would say that the FQHC does check, some of the most boxes here in terms of the green, but there is a significant administrative burden involved in operating an FQHC and receiving that 330 grant. So an FQHC is eligible to own and operate a rural health clinic, a critical access hospital, and a critical access hospital that is city owned or county owned is eligible to own an FQHC. So it's possible to do, but certainly one of the things that would be really important to look into prior to, deciding on FQHC designation is one, the financial impact, but also weighing the administrative burden in participating in that program. So I'm going to start speaking a bit here about rural health clinic reimbursement methodologies. So as some of you may be aware that, at the end of 2020, that the president signed the Consolidated Appropriations Act. And this fundamentally changed the reimbursement methodology for critical access hospitals beginning on April 1st, 2021. So all new rural health clinics, meaning any rural health clinic established after, which was changed to December 31st, 2020, but it was originally December 31st, 2019, that, regardless of whether they're independent or, provider-based underneath a hospital of fewer than 50 beds, that there would be a change to the reimbursement methodology where starting in 2021, would be a capped upper payment limit at $100 going through 2028, rising, $13 per year effectively until 2028, until the upper payment limit reached $190 per visit. Now, this upper payment limit isn't necessarily the rate that the clinic would receive. There would be a reconciliation between the cost-based rate of the rural health clinic, and then the clinic would be paid the lesser of the cost-based rate or the upper payment limit. So say in 2028, the cost-based rate was $184. That's what rate the clinic would receive rather than the $190. And then in future years, the rate would be adjusted based on the Medicare Economic Index for primary care services, which historically has been roughly around 1.4%. So rural health clinics that were previously established prior to this date, that either the clinic was established or that the the clinic had put in paperwork for the 855A application prior to this date would be grandfathered in at using the 2020 cost-based rate of the clinic. And then that would be on a go-forward basis, it would be increased again on that NEI of roughly 1.4%. And so I had mentioned a minute ago that since that legislation varied from the RHC Modernization Act, that there are some changes that have taken place, specifically adjusting the timeline from 2019 to 2020. And in April 2021, the president signed HR 1868, which did fix this confusion. So next, I'm going to explain a couple different scenarios and kind of say, all right, well, if our reimbursement methodology has changed, what does that mean to us as hospitals or rural health clinics that have grandfathered clinics, or if we're looking to establish new rural health clinics? So the first example here is of a critical access hospital that received uncapped or cost-based reimbursement in the rural health clinic. And it's looking at the hospital had 2 RHCs, and this is rolled back to 2016, which sort of seems confusing, but it's to say, if this had occurred a few years ago, what would be the go forward impact? Because we're not at a point yet where we've seen a number of years go by where we're able to see, how this affects us either positively or negatively from a reimbursement perspective. And so we have the cost-based rate in 2016 of $154.85. And that fluctuated a bit, but ultimately increased pretty significantly over the period of time that we're looking at through 2019, up to $220.92. And that was about a 43% increase over that period of time. But if this law were to take effect again in 2016, and then we had to adjust based on that Medicare Economic Index for primary care, which is roughly that 1.4% that I mentioned, we're seeing very tiny increases annually, which ultimately is leading to this significant lost reimbursement, so to speak, where we're not able to recoup our costs. We're receiving something significantly below that. And over this period, of 3 years, it's a pretty significant, detrimental effect of $688,000 of lost reimbursement over that period. Now, next we look at this from the perspective of a hospital-based rural health clinic under a hospital with greater than 50 beds. And previous to the legislative change, hospitals that had rural health clinics with greater than 50 beds, they weren't eligible for that cost-based reimbursement. And they were subject to the old cap, essentially, which you're seeing here as independent rate, starting at $81.32 and going up to $84.70. And so when the hospital files its cost report, it's showing that there's that clinic, cost-based rate kind of going from 145, fluctuating a bit, and ultimately ending slightly down at $141, but it's not eligible to actually receive that rate. And so if this law were to go into effect in 2016 and to see some of the roll forward effects that, for hospitals that have a rural health clinic with greater than 50 beds, this is a great thing. They were subject to this, low to mid $80 rate, which now they're receiving, in the initial year, $100 going up to $139 for a 39% increase, which we know is going to continue on in future years. And so this is something, if we look at this for critical access hospitals that receive cost-based reimbursement, you're seeing this negative impact, and very significant so. And then we compare that to a rural health clinic underneath a larger hospital, and it, this kind of seems that the legislative change is benefiting the rural hospital, the larger hospital, as they get into the rural health clinic game. And it makes it more difficult for critical access hospitals to compete from the grandfather perspective. And so next we'll look at this, so we've looked at the grandfather. What does this mean if we already have an established rural health clinic? Going forward, and if we're looking to establish new rural health clinics under this new legislation, what does that mean in terms of comparing the upper payment limit rate versus what we would have received as a cost-based rate if the old legislation would have continued? And we see, similar to the previous slide, we have the same cost-based rate going across the top there from $155 up to $221. But then we see that we've substituted this new RHC upper payment limit rate in there. And if you recall, we started on the previous slide at the $154.85 for the grandfather, but then that increased incrementally at about 1.4%. Here we're starting at a much lower baseline of $100 and increasing. And as we see that the lost reimbursement is significantly greater than compared to a cost-based rate that we would have received, where on the previous slide of the lost reimbursement at $688,000, now we're up to a loss of about $1.34 million in comparison to our cost-based rate. So this is something that has a significantly detrimental effect in comparison to our costs. And thinking about this lever that we've used in the past to help defray some of the losses that we incur on clinics as we try to acquire clinics within our communities. This is something that is deterring us from looking to develop our primary care footprint via rural health clinics. Now, in contrast, in comparison to the freestanding health clinic, this is a much superior choice, but the benefit itself is not as beneficial as it was historically. Next chart, looking at the hospital-based rural health clinics with greater than 50 beds, it's the exact same scenario as it was previously. So again, this is something that we like to think of critical access hospitals that have rural health clinics. They've had this kind of special power, so to speak, this leverage that larger hospitals didn't have. And this legislative change is, sort of taking some of that leverage away from our smaller critical access hospitals and giving it to larger facilities. So it's something that we certainly need to be mindful of as we go forward and looking at our primary care footprint. And I will now turn it over to Opal for strategic options.
So thank you, Zach. When we're looking at this, one of the important things is that we look at it from a broader system-wide approach to what the revenue optimization is. As Zach pointed out, the changes in legislation, right, have really benefited some of the larger organizations and those that are not, and giving them access to that cost-based reimbursement, and not allowing the smaller organizations to take full advantage of the uncapped reimbursement that we had previously, that allowed organizations to roll in things such as specialty care and integrate specialty practices into it. So, but looking at it from a larger system approach to revenue optimization, all systems that exist, regardless of size, need to be able to leverage this, what all these different reimbursement opportunities that Zach just went through, to figure out how can it impact their financial performance. As you may recall at the beginning, I mentioned that one of the things that we look for as to whether or not an organization has actually optimized their primary care clinics. When you look at a rural health clinic, we see successful rural health clinics being able to become near break even on a per provider basis. Now, I will say that a lot of them still experience significant losses, but by tapping into these available reimbursements, they are able to get the financial upside where it is a lot better performing practice than what you see in some of the urban markets when they take advantage of that. So there's 4 specific things that we've seen hospitals and health systems do to improve those reimbursements. So the first thing is to convert eligible practices, right? You buy that freestanding clinic, maybe it's been freestanding, and doing a true analysis as to what is the best designation that provides the most advantageous reimbursement opportunity. Lining it up, using that chart that Zach just pointed out of what are the different reimbursement opportunities that are available to you for each one of these designations, and how does it apply based off of the throughput we have, the number of providers we have, the amount of advanced practice providers, how we're utilizing them within the clinic, and and what is our maximized reimbursement. And the second option is to not just convert the eligible practices, but actually to realign practices within a health system to take advantage of these. So That being said, a lot of organizations, especially larger health systems, that say they go and buy a critical access hospital. The go-to methodology for a lot of these acquisitions has been, let's consolidate. Let's bring all of the providers underneath medical group. A medical group is its own, like, wholly owned entity with underneath the hospital. However, when you align all of the clinics underneath medical group, as opposed to evaluating, maybe it's actually best to put it underneath the critical access hospital, and how we can actually align even more providers underneath the critical access hospital, even if they're providing services to the larger system, oftentimes is not taking advantage of that cost-based reimbursement, because under medical group, you're not going to be able to put those clinics underneath that, underneath some of these designations that have significant revenue optimization. So doing things the way that, frankly, maybe a corporate system always thinks of doing things, frankly, undercuts the value that rural truly brings in taking advantage of the rules that apply to us compared to some of the others to do this revenue optimization. As I had mentioned previously, integrating that specialty practice when possible, to be able to get that grandfathered provider-based rural health clinic reimbursement rate. This one is not as available to us anymore unless you are able to get it grandfathered where you already have specialty care. And how do you integrate maximizing that with further specialty care? So we were working with an organization down in Louisiana that luckily had done it under a grandfathered basis, but trying to examine, was there other specialty care when you're going through a provider needs analysis or a medical staff development plan? Is there other specialty care that it makes sense to include in the provider-based rural health clinic that you already have established, to be able to go and continue to get that grandfathered rate and maintain that cost structure that you have in there for while it is grandfathered at that higher cost-based rate? And then, of course, acquiring independent practices to continue to leverage the provider-based reimbursement. So on this case, as I mentioned, you think about, okay, buying up a practice. I would encourage you to move away from just the pure opportunistic reactionary method that a lot of organizations do to acquiring an independent practice. Doing an examination of what are our optimization opportunities for who should we acquire, and how can we do it in a way that it combines both functional, contractual, and governance alignment with a practice to really secure our primary care base, rather than acquiring it and doing things on the back end. It's thinking about, okay, hey, here's maybe we do have an independent practice that we've been looking at and thinking, maybe we should, this is right and it fits within our medical staff development plan. Examining, okay, what is the optimized way about going about this? Is it really just keeping them as an independent and actually strengthening our alignment on just a functional and a contractual basis, having them participate in our, med staff executive committee, et cetera? Or does it mean actually acquiring them because they present some reimbursement opportunity, and we'll have a stronger alignment with them if we actually acquire them, but doing it in a more strategic base rather than reactionary? So that being said, let's move on and talk about some of the characteristics that we see of some of our better performers when it comes to practices. We notice that amongst what we consider high performing clinics, the ones that are doing better across the board, there are some specific key attributes around organization, strategy, operations, productivity, value, and profit, and obviously that indicate with higher profitability. And some of those key attributes that we see amongst these organizations is clear strategic direction. Again, not being reactionary, having an actual vision and a strategic plan that embodies those core values, reinforces the culture, identifies what are the opportunities that will further strengthen those culture, and executing on that, including a formal strategic planning process that makes sure that everybody in the organization, including acquisition targets and and clinics that maybe not be on the hospital footprint, the main campus, are they aligned and a part of that strategy, and that they know what's going on in the strategy? Do you have an outreach provider-based rural health clinic, 32 miles away from the hospital, and do they understand how they fit into that larger strategy? So making sure that is constantly being uniform throughout the organization and well communicated, and this bilateral communication where you're getting feedback as to how the different components are executing on that strategy. From an operations perspective, we see better performing clinics really emphasize performance at that clinic level, really treating it as its own business unit where clerical and clinical are integrated, and they are sharing data and using that data to drive decision making. Everything around the revenue cycle management has a mentality around collections and not thinking of it. Even if you use a third-party vendor for your billing and collecting, that the front desk and understands really what it means is from an operational standpoint to be collecting, point of service cash collections, getting co-pays, doing insurance verification, all of those pieces, understanding their role and and how to utilize data to do their jobs accordingly. All right. We actually see better, higher performing clinics actually have more clinical support staff on a per FTE basis, rather than saying that they run super lean, recognizing that it's super hard right now to get additional staff, but focusing on improved provider efficiency is a key attribute. And it's not just telling providers, you need to see more patients. It's not only, okay, we as a clinic need to see more patients, how do we fit them in, and what is the most efficient way of doing that? So recognizing from a measurement standpoint, how are we measuring productivity and how we're engaging with both providers and staff about their role in generating productivity and having them be participants in understanding bottlenecks and improving workflow. And then actually having staff incentivized for practice performance, not just leaving them at a pure hourly rate, and frankly, not dealing with the staffing shortages with another pizza party, but rather actually doing things such as what we've seen, even just $100 gift card for the PSR who does has the most consistent and highest accuracy of insurance verification or patient check-in or point of service collections for the quarters, things like that. We actually see having staff incentivized around practice performance is actually meaningful in both in keeping them engaged and executing value for the organization. And then making sure that these organizations really are focusing on the community patients as the critical stakeholders, and they have a culture of focusing on what we're trying to do is preserve high quality patient access, expanding high quality patient access. What does that look like? And as opposed to what does it mean for us? It is, what does it mean for patient access? And how can we do that as a high quality of care and having good patient satisfaction, and what is our reputation? So let's talk about some specific metrics on the next slide as far as what we're starting to, of the things that we see in these organizations and how they perform. So as you'll see in here in the chart, we look at medical revenue, operating costs, provider costs, calculated total cost of net income for all practices versus rural practices versus what we see as the better performing practices. What we have seen is actually the rural practices in general, it's not surprising. They tend to generate, there tends to be a bit less medical revenue. It's a lower cost setting. We actually have been getting providers a little bit cheaper, although those numbers are going up, and our total costs are less. However, compared to the the best performing practices on whole, we're seeing rural actually do a little bit less than what we're seeing in the all practice data. Now, that does not mean that as we dug into this, the better performing practices are not necessarily urban market practices of thinking, oh, well, because urban, they can have all these other sort of efficiencies. As we dug into this, the reason why, the better performing practices are able to have a better net income of, a loss of $72,000 per provider, as opposed to 112 in rural, is actually those that are diving into what we've been talking about as these designations of looking for other opportunities to generate income for the practice in a way that gives them a way to finance other key pieces of operations, to be able to address a lot of the operational issues that we were talking about when we kicked off as to why do practices lose money to begin with. Being able to do that allows them to make these investments, and it has an exponential impact of next thing you know, you go from having a loss of 112 to a loss, say, of 90 to a loss of 80, and then getting up to this. And again, that's median level for the better performing practices. We're seeing our top performing practices get very near break even, especially when you even take into consideration the 340 benefits, the 340 beat benefits. Going on to the next slide, as I mentioned, like with regards to staffing, you'll see that the total support staff, people think of, run, how do I generate? I either have to run super lean to be able to generate staff, or maybe they have all of these staff, right? Like, of course, you can have a bunch of revenue and you can have a bunch of throughput if you have a bunch of staff at your disposal. Realistically, and people think of rural, we just don't have access to resources. What we saw is actually our rural practices tend to staff more clinical support staff and more total support staff on a per provider basis than what we're seeing with our better performing practices. And part of that has to do with realistically is that sharing of staff of having uniform scope of work for a PSR, for a MA, et cetera, and having them cross-trained, allowing a single MA be able to service multiple providers or to be able to share across multiple clinics based off of where our operations and our throughput need it, is really critical for us to be able to hit closer to those break-even points and having a better optimization. And then the productivity that we see in our better performing practices is significantly higher. 700 work RVUs on a per provider basis than what we're currently seeing in rural practices. And so recognizing that, of knowing that these are achievable numbers for our better performing practices, how do we get there? And know that it's a road to success. It's not just a simple overnight piece, and designations are not going to fix this overnight for you. The key, as we've seen, as Zach was pointing out, the regulatory changes of designations, it's about using designations to increase your revenue in a way that allows you to make appropriate investments in addressing additional operations. So with that, Zach, you want to go into some of the case studies that we've seen of specifically of what people have done with these designations and what the financial impact has been?
Absolutely. Thanks, Opal. So we have two case studies. The first one here is a system in the Mid-Atlantic region, multi-hospital system with health centers. So it was a large 600-bed short-term acute care hospital. There was a 35-bed, so small, again, thinking below that 50-bed threshold, and then two critical access hospitals as well, and a primary care physician group with a large practice, 200 practice sites and 700 employed providers. So Stroudwater looked at 4 different scenarios to see what would be the most advantageous designation for this system. So the first scenario was reimbursement received with freestanding health clinics. The second scenario would be reimbursement received as provider-based rural health clinics under that 35-bed PPS hospital. The third scenario is kind of a pre-legislative change of reimbursements received as provider-based rural health clinics underneath the 2 critical access hospitals. And then scenario 4, just to show the difference, is the post-legislative change reimbursements received as provider-based rural health clinics, again, split between the 2 critical access hospitals. And in this specific example, due to specific location and geographical issues, that none of the clinics could operate as provider-based clinics under a CAH or receive the APC payment underneath the PPS hospital. So again, scenario 1 is all of the practice locations are freestanding health centers. At this point, I think we've established that this is, generally speaking, the worst designation that your clinics can have. We see that the reimbursements received were about $8.2 million with an average Medicaid rate of $109.58 over 75,000 visits. And looking at the critical access hospital piece, that in scenario 1, they're just freestanding clinics as they were. There's no impact there. Scenario 2, that we see that again, it's a PPS hospital with fewer than 50 beds, so it is eligible for that cost-based rate. And we see that the Medicare and Medicaid average reimbursement increased by about $70 per visit, which is very significant. And we see that the variance, as compared to freestanding health center, that there was a huge pickup in terms of reimbursement of about $5.28 million. Looking at scenario 3 with the practices split between the critical access hospitals, we see that, again, this is cost-based reimbursement. There was a slight uptick based on the cost structure of the critical access hospitals as compared to the PPS hospital. It went up to $181.32. So there was a slight pickup in terms of reimbursement from the practices themselves. Now, looking below, there's this critical access hospital impact. So we see that Medicare and Medicaid reimbursements decreased by almost $9 million. And this is as a result of adding provider-based clinics to a critical access hospital, going through that process of the way that the overhead is allocated on the cost report, that there's a reduction of reimbursements from other cost-based services coming toward the rural health clinics in this case. So we see this reduction here, but again, the critical access hospitals are eligible to participate in the 340B program. So there's this huge boost in 340B revenue from all of those visits. And we see that the reimbursements received, not just from the practices themselves, had a slight uptick, but there was a significant increase in terms of reimbursement received as a result of being a critical access hospital. So as compared to a freestanding health center, it's over $7 million pickup pre-legislative change for the critical access hospitals. And then again, just to show the example here of the post change, looking at this from last year, the rate would be $100 for Medicare and Medicaid. So we see a large decrease as compared to really all of the different designations up to this point. Again, we're going to have that same critical access hospital reimbursement impact of about the $1.9 million. We're going to still get the 340B revenue. And we look at what is the total variance as compared to a freestanding health center. It's really only about $1 million. So certainly beneficial going forward, but knowing that, having gone through this process prior to the legislative change would have been incredibly beneficial to be locked in roughly at that cost-based rate, which will then be increasing at that Medicare economic index. And looking at scenario number 2, one of the things we wanted to point out is that the PPS hospital, the DISH percentage was not high enough to qualify for 340B, or that would have also been a very significant benefit in that example. And then the next case study is a multi-hospital system. So we have a 134-bed short-term acute care PPS hospital with a 25-bed critical access hospital. The CAH was looking to acquire a practice with 3 providers that were designated as, it was a freestanding health center in the same town as the CAH. And the critical access hospital engaged us to look at the reimbursement impact of the following 3 scenarios. So the first scenario, again, looking at this as a freestanding physician practice. Scenario 2, looking at the prior legislative change as a provider-based rural health clinic underneath a critical access hospital. And then scenario 3, looking at the reimbursement change post-legislative change underneath the critical access hospital. And so we see scenario 1, the average Medicare reimbursement as a freestanding clinic was about $97, $97. The reimbursement received was about $275,000. And again, this is presented a little bit differently than the previous chart, but the reimbursements received for the CAH for Medicare and Medicaid were a little over $10 million. Now, looking at this from a critical access hospital as a provider-based rural health clinic prior to the legislative change, we're tapping into that cost-based rate. So we see the rate went up by about $101 per visit for Medicare and Medicaid, which was, we almost doubled the reimbursements received from the practices effectively. Now, again, as I mentioned on a previous slide, where we see the Medicare and Medicaid reimbursements declining a bit as a critical access hospital, presented a little bit differently here, but the reimbursement to other cost-based services at the CAH were reduced by about $75,000, which slightly offset the pickup from practice reimbursement. But, again, as, provider-based rural health clinics underneath a CAH were able to tap into that 340B revenue, which was about $183,000. So the total variance from scenario 1 was about $396,000. So it was a really nice pickup for, a relatively small clinic in this example. And then looking at, just for comparison's sake, what would have happened if, this hospital had gone through the process post legislative change. Again, we would be subject to that $100 Medicare and Medicaid rate. The reimbursements received would be almost break even. It's only a $3 roughly increase per visit from the freestanding health center. We're still going to have that $75,000 reduction in reimbursement from other cost-based services. We do get the benefit of 340B, but in looking at the variance in terms of reimbursement as a freestanding health center, there's really no pickup at all from the clinic reimbursement itself. We're not getting the impact of the RHC program. We're really only getting the benefit of 340B in this example. So it is a pickup. It is more beneficial than as a freestanding health center, but it certainly doesn't have, there's not as much meat on the bone as the pre-legislative change here. And I will turn it over to Opal for some best practices.
So thank you, Zach. So going through this, and we're going to, in the interest of time, we're going to go through some of these relatively quickly, but I want, especially because I've kind of talked about them conceptually when we were talking about our better performing practices. But I want to make sure you guys have at your fingertips some things from some strategies besides, that as I mentioned, utilizing this reimbursement. While it's not as much as pre-legislative changes, there is still pickup opportunity available, which helps you again invest in addressing some of these other changes. So when we think about the strategic risk of of our options, we have to think about the fact that all of these are integrated. Financial risk and operating value and market risk. This is all interconnected. You can't look at any of one of these things in isolation, right? Quality costs money to do, which, there's always going to be market competition for somebody doing it cheaper or higher quality, and potentially both in you, which is all impacting value, right? So there's, in thinking about this, you need to look at it holistically of what are all the different strategic risks and operational improvements that we can look at as an organization to impact, and set us up for the longest term success. Whether it's looking at the overall market and what are our growth opportunities. If we already have provider-based rural health clinics that have specialty care integrated, can we layer on additional specialty care under our grandfathered higher rate and be able to take advantage of that to prop up, building up, having a better service line that creates downstream revenue and improves our overall financial performance. Well, what does that look operationally, right? How do we actually integrate a new specialist into a practice? What does it mean for the staffing for that specialist, especially if they're only going to be there, say, in the clinic 2 days a week or 1 day a week? What are the supplies that we're going to be needed to that? Does the upside cover all of this? And does it upside not just in the practice, but also the downstream revenue? That being said, how does it, how do we make sure that this is impacting? How does this go into our overall contracting strategy, and how are we using it to make a good case with our different payers for moving towards any sort of value-based payment, or how it's going to benefit them from having, having better quality outcomes, and what are those savings? Are we taking into consideration whether or not we ourselves are self-insured, and how does that play into that? So understanding how each of these 4 vectors play into each other is really important for the hospital's organizational leadership, both operationally and at the board level, to understand where do our primary care practices fit into each one of those, and what is our strategy to address each of these risks. If your primary care options do not take into consideration your financial, operational, value, and market risk, each one of them and how they indicate, you're not looking at your primary care options holistically, and it can leave you with significant exposure since these all impact one another. So moving on, looking at our, on the next slide, the organization and strategy, when we talk about best practices, looking at what leadership does, what I want to emphasize on this slide that I didn't talk about previously is really how cyclical this is. And notice how, this thing is constantly evolving. You want to make sure your practice managers and the practicing providers are involved in this chain, because what they do and their understanding of what the strategic direction is for the organization and the place of primary care in this, right, informs how the staff works, which informs what the work processes, systems, and resources are for actually executing that strategy. Your success of executing the strategy is absolutely dependent on both and how you engage your practice managers, providers, and staff in those clinics for developing that primary care strategy for your rural. So you have to really rely on this bi-directional communication. It's not just a top-down of, hey, here's what the board has decided our strategy is. The board needs to be able to get feedback from those people who are in the clinics on a day-to-day basis as to understanding the feasibility and understanding the additional risk associated with executing that strategy. That being said, going into provider complement, right? This is where you're doing your medical staff development planning, understanding your service area, and understanding that when it comes to alignment, you can buy it, you can build it, or you can partner for it, right? We don't always have to buy it, but understanding your primary care options and what the appropriate designations are will inform you what is the best, what has the best ROI. Is it buying it, building it, or partnering it for building out that primary care and what other services that you're going to provide, but especially around primary care. And I would say, because it is so important to have really strong alignment with your primary care, I know people's instinct is immediately go to buy, but I want you guys, and I actually agree with that instinct, is usually pays off if you do it correctly. But I want you guys to do it in an informed way where you really evaluated these primary care options, determined their feasibility, and projected out the impact associated with any conversions or integration or potential consolidation, understanding where it fits into your capital plan about eventual consolidation, and where the market demand is for driving this. So again, buy may be the right instincts, but doing it in a very informed way is critical to its overall success. And one of those next pieces of that is moving on to the next slide with what is your availability of people who are going to actually operate these clinics? Those practice managers, understanding, do you have a practice manager or do you have a practice supervisor? We recognize that most of the time for a lot of these clinics, people are going to have to wear multiple hats, right? I am working as an MA who is rooming patients, but I'm also technically the supervisor or the manager of the clinic. So I'm in charge of everybody else, but I'm also working full-time as this. And maybe I have, one administrative day a week where I'm supposed to be wearing more of an administrative hat. The success of these practices is really tied to whether or not you can actually lift up people into actually assuming that manager role in the true expectation of what a manager needs to do. Okay. What you need to do is invest in your staff and train them to think like a manager. Have them have the autonomy of, okay, understanding what decisions can they make. Is there a certain cash spend that they're allowed to actually just, hey, if you can solve a problem for $500, go solve it. You don't need to go and ask the CFO or somebody higher up the food chain to be able to spend it. Finding out what that level of autonomy is for them really can help, and training them how to make those decisions and how to utilize data will drive your practices forward so much more when we recognize that we can't get additional staff. So who's our best and our brightest in the practice, and how can we have them engage and think strategically about improvements and understanding, going beyond, hey, you're responsible for dealing with conflict that happens between staff people, or, oh, so-and-so's out sick, go, fill in for them or find somebody to fill in for them, and just producing reports that they hand off to somebody else to make decisions with. Really training them up from supervisor to manager, regardless of what their title is probably, I would say, in today's market, one of the single most important things you guys can do for making sure that you're really setting yourselves up for a sustainable financial success with based in your primary care. And the reason why I emphasize that so much is because exactly the success of primary care is going to drive the overall success of our overall healthcare organizations. So this is one of the areas that I would prioritize if you are going through your strategic options from what designation that is best for you. This is an area that I put as a high priority of where do I can make investments. This is one of the few places where you may be better off investing in training than another body. right? Which I'm sure if there's any physicians on the phone, they'd be like, nope, I need another MA. But and so they might argue with me on that. But this is actually, from what I've seen, this tends to generate a higher ROI. That being said, provider engagement is absolutely critical. And people think about engagement of, okay, well, we ask our physicians for their opinion on things, but that's not true bidirectional communication. True bidirectional communication is not just asking for their own opinion, but it's also providing follow-up. What did you do with their opinion? It's going beyond their contracts and their compensation. But I have to say, actually reviewing with providers financials. People think physicians don't want to talk about the finances. That's why I sold you the practice, right? Is because I don't want to engage in the direct operations anymore. But the reality is engaging with providers about the financials and having them understand the difference between an RHC visit and its financial impact, and like, how can we fit in more of maybe some 15-minute visits versus some of the other visits, is really important for how the provider and how it interacts, is really important for actually how they set their schedules and how you deal with scheduling templates and moving that forward. So they have to be engaged on this. And then also giving them the very timely feedback, because one of the caveats about the primary care options of looking at designations is people think if I do an RHC conversion, I don't have to worry about coding anymore because I get paid the same for a 99211 versus a 99213 versus 99215. Guess what? You still have commercial payers. They didn't go away. Neither did self-pay, even if you're on a sliding scale of reimbursement on their self-pay. So making sure that you're still staying on top of billing and coding issues and providing that feedback to providers is critical. So just a couple of more slides to go through really quickly. With regards to the scheduling, you have to have that service philosophy of constantly evaluating what your patient wait times are. That door-to-doc time is absolutely critical. Patients now have other options, including the expansion of telehealth and teledoc that they've gotten used to. Walmart and Walgreens are all over the place with expanding primary care. And so making sure we're not losing patients because of scheduling issues. So how do we make sure we have those same day visits for sick care available within our practices? And then going through and like, how do we adjust the schedule, having set policies for that, and making sure patients are getting automated patient appointment reminders, both we see 10 days out, 3 days out, and 24 hours in advance with regards to those appointment reminders. It's not just one time anymore as far as engaging with providers. So moving on with regards to staffing, one of the things I want you guys to consider doing is a time motion analysis of understanding where are you wasting time on that door-to-doc time. Of just take 30 minutes with the provider and document every minute that provider spends. What is their time that is wasted? What is their time actively seeing patients? What are the things that they can delegate? I start with providers, but I also look at this across the staff. Definitely focus on advanced practice providers, especially in Oklahoma, where we have a restricted practice state, how we can use APPs. We can't utilize them nearly as much as some of our other states can. And so making sure that you're using them the best you can and not wasting their time, and how you're unlocking physician time is critical to improve those throughput. So the last little piece is about revenue cycle. So this is a picture of what revenue cycle looks like overall. The last slide that I have is a checklist of a to-do list of what you want to do, really focusing on that front end part of the visit of how you address your bad debt policy, and you're looking at your measurement systems and what the cadence is, and setting up those workflows specifically around revenue cycle on that front end piece of people who are actually in the clinic. You have not offloaded your front desk of checking in, even if you're using a third party billing company. So not forgetting about revenue cycle just because you use a third party billing. And if you do utilize a third party billing, making sure they actually understand RHC billing. It's amazing how many do not understand it at all, and not catching where they are missing that money. So that being said, I appreciate everybody joining us today. I hope having this to-do list and these checklists, you can just go back to your practice, hand them off to your practice manager who's acting like a manager, to be able to go through and be like, okay, I've done this, I've done this, I've done that. And have some really key takeaways of not just what options to consider and how the regulatory changes have impacted those options, but then what to do with any upside that you pick up from those options to invest in real long-term sustainable operational improvement for your practices. So again, thank you everyone for joining us. Please, here's our contact information. Do not hesitate to reach out if you have any questions, because we know we just covered so much on today's presentation, and we really appreciate Laura you have for having us today and joining you guys in Oklahoma.
Thank you very much.
Yes, thank you both. This has been great. Thank you for the case studies and the checklist information. We have a few folks on the call. Real quick, I wanted to just check and see if anyone had any questions before we let everyone go. All right, well, as we move forward, if you have any questions at all, please do not hesitate to reach out to me. With that said, thank you for your time, and everyone have a great rest of your day.